So anyways, today's topic, she's going to be diving into asthma. The effects of asthma, what causes it, all kinds of stuff, I guess. I have no idea. I'm sure she's allergies as well. And I'm assuming it's going to somehow lead into how people with asthma are going to be affected by, or could be affected by COVID as well, I'm assuming. But there goes my arm. I'm going to let Doriana start in a sec as soon as she finds a spot to talk in. Yeah, our connection's bad. So hold on one sec, guys. All right. What kind of cereal are you eating, Nydia?
Huh?
Hey, what kind? Oh, oatmeal. Very healthy. I've been eating it every single morning except for Saturdays and Sundays.
I've been making better food choices.
You know, every time I eat oatmeal, my daughter eats half of it every time I make it. So I've been trying to cut down my carbs for her. So I've been sticking with eggs. I'm kidding. I'm kidding. All right. She's still looking. Anybody here have asthma?
Sorry, I was on mute.
I had it as a kid.
Oh, really?
Like I had a puffer. Yeah. I had puffer for years. Yep.
I think that's better. Can you guys hear me?
Yeah, absolutely.
Yeah. Sorry, I don't know why sometimes it's just shoddy the reception, I guess.
Okay. No problem. Maria, can you pass me my headphones? It's in the drawer. Just because I know they're going to hear Selena. Can you guys hear Selena's music in the background or no?
Not really.
No.
Here I am.
We can hear her though. She's so cute.
Hey?
We can hear her though. She's adorable.
She's something. Maria, pass the headphones because it's going to get loud.
Good job, baby. All right. Okay. Sorry.
No problem.
I had to get my phone. So yeah, asthma. Anybody have asthma? Any sufferers? Okay. Well, that's good. Yes. We don't have to talk about asthma. I just thought maybe somebody would have it and wanted to sort of go over it. So feel free to change the subject if you want. There's some new guidelines on it. That's why I thought maybe it would be good to go over.
Let's go.
Absolutely.
Yeah. So, I mean, generally speaking, I think asthma is an airways disease. So it involves inflammation of the airways and a hyperreactive response of the airways. So,
kids ruin everything.
Sorry.
Okay.
So yes, airway hyperresponsiveness. So the airways in your lungs, they overreact to stimulus. Okay, and there's different stimuli that can cause asthma. And then what happens at a cellular level is that there's inflammation happening there. So the inflammation can be chronic and can cause things like changes at the cell level, and that can cause long-term problems. And also, in a way, if you think about the airways almost being swollen, so that's the other thing that we kind of worry about with people who are asthmatic. So generally speaking, people who have asthma really, if they're well controlled, should not really know that they have asthma, right? Their lives shouldn't really be affected if they're being treated properly. And I think that's one of the big mistakes that people make, is that they think their asthma is controlled, and then if you actually really ask them the questions, they may not be well controlled. So basically, asthmatics should be able to carry on full physical activity. They should not be having to miss school or work because of their asthma. They should not be waking up during the night because of their asthma. And they should, they should basically be able to carry on normal daily activities without having to, to stop or change because of the effects of their asthma. So I guess the biggest change in asthma treatment in the last year and a half has been that up until then, we used to you know, there's different levels of asthma. So I don't know if anybody here ever has to use a puffer, just like, let's say before a workout. Okay. So a lot of people will have to take like a couple puffs of Ventolin, which is, or typically it's Ventolin, the blue puffer. They'll take a couple puffs of that before their workout to kind of open up the airways. And that used to be the only treatment for people who have very mild symptoms of asthma. And then in 2019, there was an update to the guidelines. And if anybody wants to look at them, they're actually, they're online and they're not like, they're a pretty easy read. The summary of the guidelines is pretty good. They're called the GINA guidelines, GINA. And so now it's just a bit more of an aggressive approach to even mild asthma. So if you have asthma that is affecting you less than twice a month, you can probably still get away with your we'll call it Ventolin, but that's just a trade name for the medication. It's known, the medical kind of term is a short-acting bronchodilator. But we used to basically say, just take that when you need it, if you're having symptoms that are pretty infrequent. And now the change is basically, if you have symptoms twice a month or more, which is still very mild, those people as well should probably be on a daily or regular use of an inhaled steroid plus a short-acting beta agonist or something like Ventolin. And there's combination puffers that you would take for that. So that's probably the biggest change, is a little bit more aggression in the way that we treat even very, very mild asthma. And that basically came out of many years of seeing that doing that and taking that approach will reduce the chance of somebody having a severe exacerbation or a severe flare of the asthma. Because once you have a severe flare of asthma, the chances that you're hospitalized, you know, goes up. And so just being on that very low dose of the inhaled steroid sort of most of the time will prevent that from happening and will probably preserve lung function for a longer period of time. A lot of people get very afraid of using inhaled steroids. Just out of curiosity, do people have people kind of had that kind of like steroid for asthma?
I haven't, but I know when I used to play hockey, I remember having a friend, and he said, like, I remember his dad giving him crap because he's like, he didn't want him to take the puffer too much, right? I'm pretty sure it was I'm like 99% sure it was Ventolin. Because his dad would say, like, if you overuse it, it's going to make your lungs weak and you're not going to be able to support breathing on your own, right? So is that still true, or?
It's actually completely the opposite, right? That can be very dangerous, and it's this fear of the I think it's a fear of the word steroid in general, right? Even when we're talking about skin disease and putting steroids on people's skin, you know, people get very afraid of the word steroid, and they think that it's the same as taking an oral steroid or prednisone or something like that, and it's not. That being said, the approach to asthma treatment is always the lowest dose of steroid possible to maintain your symptoms. So typically what we'll do is take a, sorry guys. Typically what we'll do is start people on a dose that gets their symptoms under control, and then step down from there. So the idea is that we want you to be on the smallest dose of steroid possible to keep your symptoms at bay. Okay. But sometimes what we have to do in order to get there is we have to put you on a higher dose, keep you nice and stable. And then at around the 3-month mark, reevaluate your symptoms and say, okay, you know what, you've been really, really good at this level for 3 months. So now we can consider kind of taking you down a little bit and seeing if we can control you there. And we basically work down until we get to the dose where you're not having symptoms. But the dose is as low as we can. So if we were to go below that even more, you're going to start to have symptoms again. And that's where we know your cutoff is. So that's the approach that we take now. And then of course, people will generally always have what we call a rescue medication or a rescue puffer for their asthma. So there's two kind of, well, there's more, but the two basic lines of treatment for asthma are your steroid and your rescue medication, which is your bronchodilator. So your rescue medication is the one that you take when you're having symptoms right then and there, and it will open up your airways and give you relief. So if I'm having an asthma attack, I'm coughing, I'm short of breath, I have wheezing, I'm going to take a couple puffs of my bronchodilator, and it's going to make me feel much better. So, so that's what you take sort of before a workout that you know is going to be a bit intense. Whereas the other one is your steroid. So that's going to be the one that you're going to be on all the time, sort of on a daily basis, regardless of your whether you're having an episode or not. Because that's the way I explain it to patients is that's the medicated part. That's the part that's going to keep your inflammation in your airways at bay so that you're not going to get these flare-ups as often. Okay. So there's your daily steroid, and then there's your as needed rescue medication. And now we're saying that if you're having symptoms more than twice a month, you're going to be on both of those most likely on a daily basis now. And there's different triggers for asthma. Some people have asthma just as a diagnosis in and of itself, right? So they just have very hyperreactive airways. They have inflammation of the airways. Other people will have asthma that's triggered by certain things. So there's exercise-induced asthma where people will only have symptoms during physical activity. And those people can probably just get away with pre-treatment before activity, if that's truly the only time you're having symptoms. And then there's people who have viral-induced asthma. So they get a cold, and that's a trigger for their asthma, okay? So even those people should probably be on a fairly regular dose of steroid. If you think about it, so it's kind of like I'm treating the asthma, keeping it at bay so that when I know this trigger comes along, because I can't predict when I'm gonna get sick, my body's already, you know, my airways are already nice and stable and ready to deal with the problem. So that's that. And in terms of just, you know, how do you know that your symptoms are well controlled? I kind of mentioned those briefly. And then we usually talk about an asthma action plan with patients, right? So, you know, especially for kids, you might, I don't know if you may have children or nieces and nephews who have asthma, and there's this approach that's like red light, green light, yellow light. So green light means you have no symptoms, you're not waking up at night, you're able to do your exercise, you haven't missed days of school because of your asthma. You know, yellow is that in between, and then red means that you're having frequent symptoms, you're waking up at night, you can't partake in your physical activities or sports because of your asthma. And depending on where you are, you know, your physician has to readjust your dose, reevaluate your medication, and then step it up from there or step down wherever you are. Allergies is another trigger for asthma, right? So people who have environmental allergies, and a lot of times you'll hear the word atopy or atopic. So somebody who is atopic, typically those are people who suffer from allergies, asthma, and eczema. We oftentimes will see those three things together. It's like a little triad. And they just have, those people just have a higher level of, let's call it inflammation, okay? Just general, I like your background, Margaret. A higher level of baseline inflammation. And so they're prone to that sort of allergic response in terms of their airways, their skin, and they tend to be more prone to food allergies as well. So, so that's the word atopic and atopy. But yeah, so generally speaking, we want you to be able to partake in your daily activities, exercise, without being limited by your asthma. And if you are, then that, like if you're having to adjust what you do, and some people do it very subconsciously, like they don't even really know, but they'll be like, oh, you know, it's funny, I have been sort of subconsciously reducing my intensity, or, you know, just kind of altering, you know, my exercise a little bit because I know that that's going to make me feel short of breath. And it's almost like they get so used to doing that they don't even realize they're doing it anymore. So if you're doing that, or, you know, if you're having to take those steps, then that's the time that you want to kind of talk to your doctor and see what else you can add. Because it's not just steroids and bronchodilators. There are a few other medications that we can use about getting your symptoms under control. So asthma really, you know, it's one of those things that I think people underestimate how serious it can be. And they are sometimes a little bit hesitant to treat it the way it should be treated, or as aggressively as it should be treated. But it's definitely treatable and controllable, and should not interfere with your daily activities and your level of functioning and your level of fitness.
So if you have people saying, you know, I want to become fit, but I have asthma, and they're kind of using it as a crutch, should they be? Because I've dealt with a lot of people where they've been super, like, hypersensitive towards, like, oh, I can't do CrossFit, it's too high intensity. And I'm like, well, you're just not going to try to go 100% your first time. It has to be a gradual process, and understand that you're on your own path. You're not, your goal isn't to do the same thing that the person next to you is, right? And it's got to be a longer progression, especially because if you're starting behind an 8 ball, essentially, it's just going to take a longer time for you to catch up, right? But I know some people can be super close-minded, and then some people, like I use like certain people, some old members that, you know, had a hard time like jogging for 30 seconds, and then ended up, I remember that her first time doing a 5K run, and she never thought in her life she'd be able to do that. But she was one of those people. I was like, I was comfortable enough because she was a friend. I would tell her like, listen, you got to start somewhere. But some people are so closed off where it's like, I have asthma and I don't want to offset it, and I don't want to do anything to, and it's going to lack, it's going to, their fitness and their health is going to suffer as a result because of their hypersensitivity. So how sensitive should I be towards that? You know what I mean? So this way I'm giving them, like, I don't want to be biased, and I only know what I know, but I want to make sure I'm providing proper, I'm communicating properly.
Exactly. Yeah. You don't want to put them into a full flare and then you're, you know, having to go to the hospital.
Oops.
Exactly. And sometimes it's fear, right? They may have had an exacerbation before, a flare-up that was very scary to them, and they just don't want to ever go back there and experience that again, right? Because imagine what that feels like. You can't breathe, right? It's not a nice feeling at all.
I find it's the same thing as dealing with people who have back pain, right? Because they're just so scared of, like, I can't use my back because my back hurts. But if you don't use your back, it's going to get weaker, tighter, and it's going to make it worse in the long run, right? It's trying to be comfortable enough with them to understand, like, it's a process.
Exactly. And so absolutely, yeah, I think so. Somebody, especially if they're new to CrossFit, number one, you know, if you have that knowledge already that they are asthmatic, I would basically start off by saying, how well is your asthma controlled? For example, in the last month, have you had to go to the hospital for an asthma attack? How many times in the last 2 weeks have you had to use your rescue medication? Because if they're using Ventolin every single day, their rescue medication, they are not well controlled, and they should not be starting a new exercise program, right? And so that would be my sort of red flag. So if you've used your blue puffer or whatever they're using as their rescue, if you've used that every day for the last week, I think you need to go into your doctor first, get your asthma under better control, and then we can start this program. And then once they can say, I've been really good for 2 weeks, I have not really needed my rescue medication, I'm not waking up at night, I haven't had any issues with wheezing, absolutely. Start slow, monitor them. They'll know their asthma symptoms. And then if they start to sort of become symptomatic, that would be your cutoff. And then you go from there, right? You can build up as their tolerance gets better. And also make sure that they're pre-medicating, right? They're taking a couple puffs of their bronchodilator before their session. So, but it shouldn't be limiting them. It really shouldn't be.
What are some signs of asthma attacks? Like, I mean, does it start off gradually and there are things that you should look out for and then progressively get worse, or?
Yeah, so your classic asthma attack symptoms. So the big one is shortness of breath and wheezing. So that kind of noise, that almost like that whistling sound that you can hear. So shortness of breath, wheezing, cough. Okay, so a chronic cough or constantly coughing can be a sign that somebody has asthma. Okay, they might not actually think they're short of breath, but they're coughing, and that can be a symptom of asthma. One of the things that we look for, like physicians look for, but again, like, you know, so for example, like parents who have kids with asthma, they'll know to look for this, is signs of respiratory distress. So for example, if you're sitting, right, and you're breathing, you shouldn't know, like you should not see that I'm breathing. I shouldn't see that you're breathing, other than, you know, a mild kind of up and down motion of your chest. When people are starting to feel short of breath or they're having distress, they start to use muscles that have to kick in to help that diaphragm and the lungs expand. So some of those muscles are the neck muscles, like these scalene muscles. So you'll start to see what we call accessory muscle use. So the muscles here will start to indraw. So you'll start to see, like, I don't know if you can see, but it'll kind of do this thing, you know, where you get that hollow kind of in your collarbone. So that's not normal, right? When you're just sitting, doing activities and breathing, you should not see that. The other place you'll see it is in the abdomen around the rib cage. So again, accessory muscle use. You'll start to see that they start doing what we call indrawing. So they're going to start breathing, and you can actually see the muscles kind of tucking in under the ribs almost, okay? And that's a really useful sign, especially in kids who have asthma, okay? So once you start to see that those abdominal muscles are being used, then you know that they're having a bit of trouble breathing there, and that they're having to use those muscles and kick them in to support their breathing. And then there's another one that we call tripoding. So I can show you what tripoding is. And if you see this, then you know you're in big trouble and you're very limited. But it's basically people will sit in a tripod position. So their legs go out like this, their hands are in front. And that anatomically, without even knowing it, patients will do that because it opens up their airways, it opens up their rib cage just to produce more space for those lungs to fill up. And that's a bad sign, right? So if you ever see somebody tripoding, then you know that they're in trouble and you need help quickly. But those are the things that you would look for, you know, primarily is shortness of breath, cough, wheeze. Those are the big ones, right? So if your kids are like, let's say they're playing soccer, you know, and everybody else is running around and they're fine, they're keeping up, and then your kid is kind of having to stop, catch their breath, you know, cough, 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 that would be a sign that possibly, you know, they're having some symptoms of asthma there.
I've been told that, you know, if someone has kind of like a asthma attack kind of thing and they don't have any puffers, the best thing to do is give them caffeine, right? To help open up their airways. How do you know how effective that is? Like how paranoid I should be if like, or how relaxed I should be in knowing that, oh, it's okay, I got some pre-wad, I'll give it to you if you have a asthma attack, or if it's like, you know what, you should be super concerned, or maybe, you know, think about telling the person to not participate if you know if they're, you know, hypersensitive with asthma and they don't have their puffer with them.
I've never heard that. I've never heard of caffeine as like as an emergency kind of rescue medication. So I can tell you that it's never come up in any like medical literature I've read. So I wouldn't put a lot of weight to that. If I was running a class and somebody started having symptoms, you have to stop. They have to stop. They'd have to stop and get reassessed. No more activity until you know that they're comfortable or that they have their puffers on them, right? That's the other thing. You know,
what do you do if there's no puffers around and and you know they've asthmatic? How quickly do things can potentially become serious?
I mean, if it's exercise induced, stopping the exercise should help, right? But if they're just having an asthma attack and it's not exercise induced and they don't have puffers on them, I think you have to use your judgment, right? When do you call for help, or when do you have to bring that person to the emergency room? And any of those symptoms would be that, right? Or I should say, you know, how quickly can you get a hold of their puffers? Because if you can get them their puffers relatively soon and give them their doses, like, you know, chances are they'll be fine. But if they're showing any significant signs of respiratory distress and you don't have time to get to a puffer, then you know, then that would be cause for more concern and having to get them help, you know, very quickly. And some people, you know, it's just that they've never seen it before. They don't know. And I remember one time when I was a resident, I walked into an exam room and there was a little boy and his mom sitting in the room, and he was, you know, obviously struggling, using lots of muscles to sort of help him breathe. And she, you know, didn't realize how severe it was and how much trouble he was having. So when I kind of walked in, I saw him and I became quite obviously concerned. She was like, well, what do you mean? You know, but the problem is that when somebody's in that situation, they can decompensate very quickly. So they might be fine and kind of struggling a little bit 1 minute, but then they can decline quite rapidly. So that's why you want to get your hands on either their puffers very quickly or have them, you know, seen in an emergency department quickly, because it is unpredictable. You know, you don't really know necessarily how much time you have. So, but people who have a history of being asthmatic are generally, you know, they're usually knowledgeable with their symptoms. I would say the biggest downfall is not having their puffers on them. Just give me 1 second. Yes. Yeah, so always have their puffers on them. Same thing with an EpiPen, right? Most of the reasons that young adults die from anaphylaxis is because they don't have an EpiPen on them.
Is an EpiPen, I guess, can you use an EpiPen if you're having an asthma attack if you don't have a puffer? Is there any, I guess, a substitution?
No, I wouldn't recommend.
No? Okay.
No, I
okay.
think that would help. Usually what happens in somebody who's having an asthma attack, if they have to go to emerge, they'll be put on a nebulizer. Okay. So it's, I don't know if you've ever seen, you know, even on TV or whatever, but it's almost like a mask where they aerosolize the ingredients of steroids and stuff, and they breathe them in that way. And that's usually how they treat like an acute asthma attack.
I had asthma as a kid growing up, until I was a teenager. I had a puffer. And then I just remember just not using it ever again. So does that just sort of like, does it go away, or do you just, like, as I started exercising more, did I just get better at breathing? Like, I don't know. I was wondering about that.
Actually, that's a good question. Asthma and even allergies in children are oftentimes, they are outgrown. So chances are, for whatever reason, when you were younger, your airways were a little bit hyperactive, and you did have some component of airway hyperreactivity that got better as you got older. So and that's the other thing, right? Is that people will say they have asthma, but they haven't actually been diagnosed properly. So you know, little kids will often have what we call wheezing, okay? But little kids who wheeze, we know that a lot of them do progress to develop asthma as they get older, but a lot of them also don't. So it's not necessarily that just because you have a wheeze as a child, you're going to end up an asthmatic. A lot of times those kids outgrow that wheezing. And then the other thing is that sometimes, you know, let's say a 10-year-old comes in and he's had a couple episodes, and I say, well, he's asthmatic. That's not really the way you should be diagnosing and defining asthma, right? In order to properly diagnose it, you really should be having pulmonary function tests done. I don't know if you had them done, Nadia, when you were diagnosed, but you have to, you have to breathe into a tube really hard, really fast, and they actually your lung volumes. So that's how you diagnose asthma. So putting somebody on puffers without having that diagnosis is really not a good approach, right? We're supposed to, as physicians, have a good, have an actual diagnosis, a documented diagnosis with pulmonary function tests to diagnose asthma, and then treat from there on. Not to say that I won't treat kids with wheeze with puffer sometimes, but I won't call them asthmatic until they're old enough for me to actually test them and diagnose them. But yeah, a lot of times you can outgrow that wheezing, and as you get older, it just goes away.
Okay, cool.
Yeah.
So are puffers only prescribed for asthma, or even for colds? Like, I mean, if you're having difficulty, a chest cold?
Yeah. So again, I would say the evidence isn't great around that, but you know, even personally speaking, I will say that sometimes I have patients come in and they're having, you know, a cold, a virus, and it kind of settles in their chest, and they have no history of asthma. But when I listen to their chest, they are wheezing a little bit. So I know that they have inflammation of their airways, which has been caused by, you know, whatever virus they have. So in those circumstances, I think it's very common. Again, it might be a little off label, but we do use, you know, we do use puffer sometimes to treat that, because we want to get those airways, you know, just less inflamed, so that the patient, you know, becomes less symptomatic. The steroid puffers don't work right away. That's the other thing to remember, right? It takes a few days for for the steroid to kind of infiltrate the airways and cause its effects that are going to eventually help.
So well, my son, when he was younger, had whooping cough, and then he had to go to the hospital, and then they also prescribed puffers for him. And what's the difference between like the orange puffer and the blue puffer?
Yeah. So whooping cough is a little bit different, right? Whooping cough is not asthma. Whooping cough is a virus that's caused, and it causes, you know, what they used to call the 100-day cough, right? That's called, it's pertussis. Sorry, it's pertussis is whooping cough. And we vaccinate for that now, right, in kids. And that's why we vaccinate for it, because kids who get whooping cough get very, very sick, and they definitely end up in hospital in respiratory distress. Right. So those, back in the day, they would do those sort of respiratory tents where the kids were in those tents with the nebulizers. That was because they get into respiratory distress. So whooping cough is caused by Bordetella pertussis, and we vaccinate for that now. So whooping cough is treated a little bit differently. With whooping cough, typically what we'll do, because it's characterized usually by this very
crying seal, I was told when I called 911. Does he sound like a crying seal? And it's like, I don't know what a crying seal sounds like until he started crying, and it's like, oh, that's what a crying seal sounds.
Barky. It's a very, very barky cough. Yeah, but once you hear it, you're like, oh yeah, that's what it is. So with those kids, oftentimes what we'll do is we'll actually give them a dose of oral prednisone, right? 1 dose of oral prednisone to reduce that airway inflammation, so that they don't end up in respiratory distress. But yeah, likely he was put on puffers just to kind of keep that inflammation, you know, to settle it down a little bit faster after that episode. So that's probably what the thinking was there. In terms of the blue and the orange puffers, those are just two examples of puffers. So when we talk about puffers, we have your inhaled corticosteroids, and then we have your short-acting bronchodilators, and then we have your long-acting bronchodilators. And depending on how bad your asthma is, you're going to be on some combination of those. So for example, the orange puffer, as we all know, you know, people who have asthma or know people who have asthma, the orange puffer is, you know, we all call it the orange puffer. That's Flovent. Okay, so that's your steroid. That's your steroid. So that is the medication that's going to keep your airways less inflamed. It's going to decrease the inflammation. It's going to prevent the changes at the cellular level, right? That remodeling, the swelling of the airways. That's the one that I was saying before. Even if you have mild asthma, you're likely going to be on that every day on a regular basis, okay? The smallest dose necessary to keep your symptoms at bay. The blue puffer is an example of a short-acting beta agonist, and that one is Ventolin. That's just an example of one of the short-acting beta agonists. That's your rescue puffer. Okay, so that's the one where you can use that if you're having some symptoms, right? It's there to all that puffer does is literally, if this is your airway, right, and it's constricted during an asthma attack, it opens it up like this, so you can get more air in. So it's a rescue medication. It's not treating anything. It's there to give the patient symptomatic relief and to you know, make them feel better. And that's why we say if you're using that every day, you're not treating the asthma properly, right? Your airways are so inflamed that you're needing that like every day. That's way too much, right? Your airways should be a lot less inflamed at baseline so that you don't need that medication as much. So that's just your rescue. That's just your rescue medication. That's a feel better medication.
Is there a correlation? Sorry, go ahead.
So is that a steroid as well?
Sorry, say that again, B.
Is that a steroid as well?
No, that has no steroid component in it at all, which is why I tell people that blue puffer is not treating your asthma, right? It is not doing anything for the inflammation in your airways. It is literally just opening them up so that you can obtain more air at that particular moment in time. And it'll give you, you know, a few hours of feeling better. So that's the one that you're going to use before a workout if you know that you have strictly exercise-based asthma. But that is not a long-term treatment. And you know, that would be very dangerous, in fact, right? If you're only using that as a treatment, that is not a treatment for asthma. It's part of the regimen that you're going to be on to control your symptoms.
So, Doriana.
Yeah.
Hey, so would you say that if for someone who uses their puffer before like every workout, because like I have really bad asthma, so I take it before every workout, would you say that that's just then not well controlled? Or because I have exercise induced asthma, should I be concerned about that? Or is it okay for me to take it before every workout?
My question would be, if you don't take it before every workout, what happens? Do you have to stop?
I do.
And you're not on any steroid at all?
I am, yeah, on the Flovent, or the orange one. Mm-hmm.
So I think in your case, probably what I would do is I would take an approach where I might increase your, it's not bad to take it before you work out. No, like I wouldn't say that that's a bad thing to do. I think that's fine. What I would want to do is maybe see if increasing it just a little bit, even increasing the dose of your steroid by even 25%, if that gives you better relief so that you don't feel so badly when you're exercising, so that you know, it's almost like you're reliant on that Ventolin or you can't work out.
Yeah, that's literally how it is. Okay.
Yeah, that's the approach I would take. If you can increase your dose a little bit and see if that just gives you a better tolerability for your exercise. Yeah.
Okay.
You can still use it. But what I'm saying is you'll feel better.
Okay. Yeah. Okay. Yeah, good. Thank you.
Is there a correlation between living an inactive lifestyle and having more severe asthma, or it's not related?
No, I don't think that that's so much related. That, you know, having a sedentary life contributing to asthma. There are risk factors for asthma for sure. The biggest one obviously is going to be smoking, genetics, right? Environmental allergens that can be triggers for asthma. I wouldn't say that being sedentary or obese really increases your risk. It might maybe change your treatment a little bit, specifically the obesity, not so much sedentary life, but no, I don't think there's a direct correlation between inactivity and severity of asthma.
But if you are more active, you'll see more positive, like you'll be able to manage and control your asthma better, or it's the same amount, it's just that you just know how to when to take drugs and when not to.
Yeah, I mean, I don't know the answer to that scientifically. The only thing I would maybe wonder about is somebody who has a really good exercise capacity and exercise background, if they are better able to, if they've, just improved lung function, right? Improve your lung volume, that kind of thing. And that might give you a bit of an edge. But yeah, I don't know the actual scientific data behind that, if there is any.
I wish Sasha was on right now, because she would always, like, not every workout, but most workouts and every single competition, she would take Ventolin right before her workouts. But other than that, she would never be, she wouldn't be puffing away. But I wish she was here so I could ask her to.
Does stress induce asthma?
Stress can cause, yeah. Stress can be a cause, a trigger. But yeah, like if she was taking it before every workout, but then she was like A-okay for everything else for the rest of the day, I mean, again, that maybe she just had that strictly exercise-induced asthma. But yeah.
I don't know if I'm going down that hole, but do you think if people who have asthma and were to get COVID, would that make things a lot worse for them for their breathing capacity? Like, are they more at risk? No.
Absolutely. So having a respiratory disease like asthma would definitely, because we know that COVID causes what we call an endotheliitis, right? It's an inflammation of the endothelial cells, which are the cells that line the insides of your bodily structures, your airways, like that.
Like snow.
So COVID would cause an inflammation there on a background of inflamed cells. So asthma would definitely be a risk factor for having a worse case or outcome with COVID. And the recommendations for asthmatics were just to continue doing what they were doing with their puffers. During the pandemic, just keep doing what you're doing with your puffers. And then, obviously if you have asthma and you're having symptoms of COVID, definitely to get tested. And you'd have to be monitored, fairly closely, because people with asthma when they're older, not young people, but elderly people with asthma also would benefit from certain vaccines, right? So we recommend pneumococcal vaccine for people who, especially for everybody over 50, but especially if you're over 50 and you have asthma. And then over the age of 65, people get another pneumonia vaccine. Sometimes that's given a bit more frequently if you've got certain underlying respiratory conditions, but it's important to protect the lungs, right? So vaccinate for any other lung diseases if you have asthma, because you're going to be more prone to developing more severe disease than those other things.
Doriana, another question regarding vaccines is, because of COVID, is it a good idea to get the flu vaccine this year more than, for example, last year or whatever?
Yeah, I don't think that there's we haven't seen a correlation, or at least not one that I've heard of or that I know of, between having your flu shot and being better protected against COVID. I don't know that there's a direct correlation there yet, but I'm a, strong believer in the flu vaccine anyways, as a baseline. So I would do it just, routinely regardless. But yeah, I don't think the science has been done yet, right? Because it's new, it's still a new virus. There's lots of research being done. But at the beginning of the pandemic, I remember hearing something about it possibly giving a little bit of protection, but I don't think that's necessarily, hard science as of right now.
I'm sure people it's a lot of people are talking about it right now. Like, if they were to come out with a vaccine next month, would you take it? They say, like, people are asking, like, if they found it next month, would you take the vaccine? Right. And I'm sure it's super controversial because some people are like, oh, they're going to take it, and people are trying to make money, and you don't actually know if it works, and we're still guinea pigs, blah, blah, blah. Especially because it's usually a longer process to figure out a vaccine, right? You can't do it within, again, they say you can't do it within like 4 to 6 months. It usually takes a year or longer. Would you take it?
If it was like FDA approved, and I knew that they were doing, because I know like the UK, they have a start, right? They're already doing clinical trials. Yeah, I would. I mean, I think when it comes to like, we hear this all the time with medications, right? I work with a physician who's been working for, I don't know, maybe 25 years now, my partner, Donna. And I remember when I first started practicing, she would always say, you know, I don't use a medication unless it's been out for 5 years. And like, you know, 10 years into practice, I kind of went, oh, now I get it, right? Because a lot of times we see these new medications, and then 2 years later, it's like, oh, you know, this one can cause whatever, blah, blah, blah. So I think in terms of general medication, I'm a little bit more cautious now. I don't jump on bandwagons as quickly as I used to. But with something like this, I think my approach is, yeah, if there was a vaccine for this, I would definitely do it. I mean, do you guys remember H1N1 in 2009? So I was pregnant with Brock at that point, and I could not get the vaccine in my hands fast enough, right? So again, that was a really expedited, process. That vaccine came out real quick. But in that circumstance, right, and in this circumstance, I would say that the risk of a vaccine developed still under, good clinical under good clinical conditions would be a lot less than the risk of the vaccine would be a lot less than the risk of getting COVID. So that's kind of the approach that I would take, right? What's the risk benefit? What's the risk benefit? With medications, I can give you this brand new one that's supposed to be really good, but if you're on your old one and it's doing a pretty good job, as it is, do we risk changing for maybe minimal benefit and maybe risk? Maybe that's not worth it. But in something like this, where it's like there's COVID, which we know can be very, very dangerous, and we have a vaccine, I think the risk would probably, not outweigh it.
Yeah, I think almost like how we talked about it last week about, what we think about doctors, just because it's kind of like a black hole where we don't really know a whole lot about, your backgrounds, your responsibilities, all the other things, other than you guys all make $300,000 to $500,000 a year, right? I think our lack of knowledge with the FDA, because we don't know, again, I'm speaking from my own experience or, my own opinion, where I don't know enough about the FDA. So you hear so much pros and cons about what everyone has to say because everyone has opinion about everything, and in trying to make your own decision. But I think I need to take more responsibility into looking up FDA and the regulations and how serious they are, because we think that, again, you hear so many people talk about, people are trying to make money, and it's like, are they taking is it 100% like scientific approach, or is there a emotional fear-based approach where they're like, hey, we got to put something out there to help the people, but we don't really know if it works 100%, but it works a little bit, so let's help people. Like, but I don't know. I haven't taken the responsibility enough to know about the FDA, but I know a lot of people are so quick to come up with opinions, but we're still being biased because we haven't taken the time to know enough about everything and know everything about both sides.
Yeah, and I mean, I think that there's always this underlying thought that there's a conspiracy behind pharma, right? Pharma is this big bad money making like conglomerate. It's like, no, pharma is there to make medications to save your life. That's what pharma is, right? I mean, are there areas of it that maybe are a little bit corrupt in the sense that, like, yes, we know there are cases where doctors get kickbacks from certain pharmaceutical companies, blah, 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 right? In general, look, pharma companies make medications because they want to help people. They want to cure disease. They want to, prolong life and improve quality of life. And that's why we prescribe those medications, because we want to do the same. I'm not going to give you a medication because I'm getting a free golf game from a pharma company. That's not behind my decision making. So yeah, I mean, I think, and also let's look at the reputable sources, right? So when this vaccine does come out, is it going to be recommended by the CDC? Is it going to be recommended by the WHO? Is it going to be FDA approved, right? So let's make sure that the resources we are looking at are reputable ones and not just sort of random, you know, things that you can find anywhere on the internet.
So when it comes to people being like negative towards the FDA or the pharma companies, do you think it's just, again, this is pure a bit opinion based, do you think it's just that the 1%, just 1% of people are the ones who kind of give it a bad name, and now people are just skeptical instead of just thinking they're good? Because if you think about it logically, it's like, well, they're making things that save your life. It's proven to save your life. You don't have to take it, but you could die. But again, it's your choice. So how bad could they really be, right? So,
right, it takes a couple of ideas like that, and especially nowadays with social media and the internet. I mean, you can have, you know, a handful of people, and all they have to do is write a blog or post something, and then boom, you know, you've got thousands and thousands of people saying, oh, you know, that kind of makes sense, but none of it is based in research. And then it causes a trickle down effect, right? So yeah, I think that if it gets, you know, all you really need is one person to have that, you know, idea in their head, and then it becomes a bit of a nightmare when it comes, you know, to just public knowledge and health. Sorry, I think there was a part to your question, Chris, and I lost my train of thought.
that's okay. No, because I know during the H1N1, I was in university, and my professor, we were talking about H1N1, like in the class, and he was saying that his brother worked for the company that designed the vaccine, right? And he was at dinner, he was at dinner with him, and he said, so are you going to be taking it? And he said, no. He goes, he's not taking it. He's going to wait another year or two to see what happens to everybody and then make his own decision after that. Mm. And he's like, so when you hear it like from that, it was like, holy shit, like it's crazy, because he's like, well, I'm not willing to take it because it hasn't been long enough, because it's only been around for a couple months. And again, hearing it from someone like that close to it, you know, you change your perspective, and you just don't know, right?
Exactly. And he may have been low risk, right? Like I remember I was pregnant. Yeah. And I actually called one of the ID doctors, Dr. G, who died now, but he was one of the ID gurus in Toronto at the time. I said, hi, Dr. Keystone. I called him and I said, should I be taking this vaccine? And he said, you better get that vaccine tomorrow, you know, because we knew that pregnancy for H1N1 was a high risk factor. But yeah, I mean, you know, maybe this particular low risk and just, you know, thought he could wait a little while and probably not risk anything really significant. But yeah, I think that, you know, it depends. And that's the other thing. Sorry, now I remember what I was going to say. You know, sometimes it's also just your experience, right, that affects your decision making. So, you know, and I'm not going to go down the anti-vaxxer sort of rabbit hole, but as an example, right, or even with COVID, it's this thing where when you don't see something, when you don't see this disease anecdotally in front of your eyes, right, you can have all sorts of ideas and sort of thoughts about it, you know, and then those people, when they are confronted with that illness or it hits home, you know, children who get meningitis and die, sometimes that's what changes their minds, you know. It's this sense of being sort of invincible. You know, we live in a country where, you know, community health is pretty good most of the time. And so we get a bit, you know, you kind of become a bit naive or desensitized to the troubles that exist. And so it takes an experience like that to be like, oh yeah, this is real and it can affect me. And so there is benefit in medication and treatment and vaccines and whatever you're talking about.
I think from my own personal experience, I did take vaccines. I just never took flu shots. But I was kind of, I want to say, ignorant towards the situation, and taking other vaccines until I have kids. And then you're just so vulnerable, because if anything happens to them, you're just like, okay, like now it's a whole other game. Like say I'm not anti anything, but I'm just saying, like, it would be way easier for me to be like, well, I'm young, I'm invincible, I don't care, I don't believe in, I don't need it. But the second you have kids, all of a sudden from my experience, I just changed my whole opinion, where it's like, I need to be hypersensitive, because they're my everything. I got to make sure they're taken care of. And I think it's easy for people who don't have kids. I'm going to throw that out there, but it's easier for them to have a strong opinion. But then when you're thinking about protecting your children, you're like, yeah, they're going to get vaccinated. They're going to get this. And I know it's still controversial and whatnot, but I'm just giving my own opinion, just because, again, if anything were to happen and all I had to do was give them a vaccine, I can't take that back, right?
exactly. Yeah. So, you know, and then it's, you know, I mean, and there's vaccine, some vaccines obviously maybe are a little bit more important than others. Like, you know, giving your kid Rototec, which is the oral vaccine that they drink so that they don't get the rotavirus, which is a stomach flu. I mean, is that as important as your measles, mumps, rubella or your meningitis vaccines? No, probably not, because, you know, rotavirus very rarely kills kids, especially in Canada, right? Where you can go to the hospital and get rehydrated. But that being said, you know, yeah, I mean, most of our vaccines are given for a reason, right? And they, you know, because they save lives. And you're absolutely right. You know, once you see it, especially once you see a kid, you know, die of meningitis, you realize how important it is. So, and then the flu shots and stuff like that. Also, it's you know, because you're not high risk when you're in your 20s and 30s if you're otherwise healthy. You know, you're not high risk. But you know, do you have elderly grandparents that you see on a regular basis? If you do, then you know, you can be a vector and cause a lot of damage that way. So it's just thinking about it in terms of like your whole community, right?
Yeah, I think after the first week you did your talk, and it changed my attitude. We're getting a flu shot. I'm like, I don't care if I get the flu; it's not a big deal. But it's not about me, and I never thought about it like that. Where it's like I have to think about my parents. I think about having like being around my grandparents, because if they were to get it, you know, like my dad gets a cold that lasts a month now. You know what I mean? So I think it was a different approach of just not thinking for yourself and thinking about, you know, the community. And again, if we
being annihilated with COVID, right? Just goes
Yeah.
to show how frail they really are, that whole population.
Another question for people who that talk to you and they're anti-vaccinated. Again, this is pure just theory, not, I don't want any stats, but how many of them, or is there the people who are anti-vaccine are they haven't been vaccinated in their whole life, or they just came up like, or they're
Not necessarily, right?
No.
Because when they were vaccinated, they weren't using vaccines for parents, right? So a lot of them have been vaccinated. And this real scare mongering, fear tactic, and you put that idea, especially if you give that idea or you put that idea in the words of somebody who has some sort of pull in society, right? Like a Jenny McCarthy. And then all of a sudden, Jenny McCarthy is an expert on vaccines. I don't know how that happened, but it does. And then she's writing books and she's on the Oprah show, and she's talking about how her son, she's absolutely sure got autism from his MMR vaccine. I mean, it's terrible information in even more terrible hands. And there you go. But, you know, I mean, I have a couple anti-vaxxers in my practice, and I don't think that the parents are not, they have been vaccinated. Sometimes there's actually even a difference of opinion between the parents, which can be even more interesting, right? One parent wants to vaccinate, one doesn't. You know, the issue is that then that child gets chickenpox and they bring them to the office with full-fledged chickenpox, having already been to a walk-in clinic, and asking me if that's really what it is. Now she's potentially infected everybody in my waiting room, including, you know, myself. I mean, I've had chickenpox, but again, right? So it's this whole idea of, you know, number one, get the right information, get the facts, the scientific facts. And then number two, if you're going to make a certain decision, you know, now you have to live with the decision, and then try not to make everybody else at risk. Try not to put everybody else at risk, right? Not an easy conversation to have with parents. It's not. And then of course everybody asked me, did your kids get the vaccine? Yeah. My kids have had every vaccine that is available to them from public health. So there, if that means anything. But yeah, so any other questions about asthma or anything, guys, or everybody's good? Okay, so bottom line is treat your asthma. Don't let puffers and the word inhaled steroids scare you. Much better and much, you know, safer for you to make sure that your asthma is well controlled, even if it means taking steroids, right? It's not. It's not
Dor,
yeah.
can kids outgrow asthma?
Yes, they can. That's the Nydia asked earlier. Oftentimes,
Okay.
have wheezing as when they're little. A lot of times they will outgrow it, and it won't be a problem for them later on in life. So that does happen. That does happen sometimes.
So is that, do they like grow out of it like in their teenage years, or does it like it happens whenever?
Yeah, I mean, it can happen whenever, but typically, yeah, I would say probably more in like, you know, I'm not, there isn't an exact age, but yeah, I would say like oftentimes by around the age of like 10, 11, we start to see that they just become a little less reactive, you know. Now, if you're talking about a child like an atopic child, so that child also has allergies and eczema, you know, they might just be generally more more sensitive, so they may not outgrow it as easily. But
is there a link between eczema and oh wow, and asthma?
Allergies and asthma, oftentimes you'll see those three things together.
Wow.
Yeah. Hey guys.
One more question, because I kind of jumped on the call a little bit later. Is there such a thing as a cold-induced asthma, like in cold weather? Does it induce asthma?
Yeah, it can. The cold air can cause those airways to constrict, right? And then you end up with asthma symptoms. So that would be another example of somebody who might want to take a couple of puffs of the Ventolin before they, you know, they go out in the cold weather kind of thing. So that does happen, yeah.
But could it happen like during the night only, or is that just something else?
No, that would be a bit more suspect if it's happening at night.
Because I've noticed, like for example, Ben, he gets asthma during the winter, but he only starts coughing like in the middle of the night.
Right.
So and we've seen the allergist for it.
Yeah.
And, you know, he's being treated with the orange puffer, and then we give him the blue puffer as well. So that's the way to manage it.
Yeah.
But just
for whatever reason, it does sometimes, the asthma just does get worse at night. And that's why, I mean, I don't know the reason behind that, like physiologically, but that's why one of the ways that we monitor symptoms is, are you having, one of the ways we monitor control of your asthma is, are you having symptoms at night? So if he's coughing at night, then that is a sign of his asthma acting up. Yeah. Okay, guys, everybody good? Yeah.
I'm good. Thank you very much.
All right, guys, you're welcome.
Yes, thank
Appreciate
you,
it.
Doriana.
Thanks a lot, guys.
Enjoy your
See you later, guys.
all right.
Take care.
Bye.